and it's really a tremendous pleasure to be able to speak at this wonderful meeting once again. Sadly, I cannot attend in person because of medical issues, but I am most grateful for both the invitation as well as the indulgence of Dr. Silver and colleagues from the CRT to allow me to present here today remotely. Now, they asked me to speak today on what to expect from your MPN therapy. Now, when we ask what we expect of our therapy, we must realize that our goal is to have it be individualized. Now, to individualize therapy, we must both look at the spectrum of disease burden and risk in the MPNs, understand how MPN patients can be similar but different in different clusters, and finally, how do we incorporate the assessment of both the disease burden and risk in choosing therapy for your MPN. Now, the natural history of MPNs are really three groups. One, earlier MPNs, ET, P. vera, and myelofibrosis. At this phase, we can have symptoms, we have risk of blood clots and bleeding, and the disease can be threatening, but most typically does not limit life. The middle group, those with classic myelofibrosis, whether they started with primary myelofibrosis or progressed, these individuals clearly can have more problematic disease. And finally, those who can transform to acute myeloid leukemia or MPN blast phase. Now, when we compare the spectrum of burden between earlier MPNs and later MPNs, in earlier MPNs, we have risk to the large blood vessels, the veins, the arteries of the heart and neck and brain. We have microvascular symptoms, problems with concentration, sometimes issues of sexual function, issues of the skin. And we have symptoms. Can be itching, can be fatigue, can be headaches, or difficulties concentrating with high counts. Now, on the MF end of the spectrum, we can have a big spleen. We can tend to have more problematic issues with the spleen. We tend to have low blood counts, anemia, or a drop in the platelet count. And we can have disease-associated symptoms from the MF, night sweats, fevers, weight loss, bone pain. Typically in a spectrum more problematic than those with myelofibrosis or with ET or PV. Low blood counts can be an issue. With myelofibrosis, anemia in 75% of patients, with 25% being transfusion dependent. A low platelet count in about a third of patients, with only 10% it being problematic, and finally a low white cell count in only a minority. Now, why these low counts matter is that they can give us risk of bleeding or infection, or with anemia they can make the symptoms we have with the disease seem worse. Now, we know that patients with MF who need transfusions can get a transfusion. We know over time that this means that their energy levels can be better after being transfused, but rarely go back to normal. Now, what about the spleen? Well, it was one of the founders of Mayo Clinic, Dr. Will Mayo, who said the spleen is an organ of contraindication and mystery, in health of relatively unimportant function, in disease a menace of grave import. Now, what about the spleen? Well, one, in myelofibrosis, it most commonly is enlarged and is able to be felt below the rib cage. Two different series suggest from 65 to 90% of people this is the case. Now, why does the big spleen matter? Well, it can not only cause pain, it can cause fullness. It can lead to sharp pain through splenic infarction. It can lead to the spleen holding onto blood counts and lowering blood counts. And it can delay engraftment after someone's had a bone marrow transplant. Now, many of you know I came from the Mayo Clinic Rochester initially after I was there for 18 years. It was a wonderful place. Could be a little cool. This is a typical summer day that we were out getting some sunshine. And my wife suggested perhaps we try to work toward getting to a warmer Mayo Clinic. And with that, we moved to Arizona back in 2009. And while there, I have become quite fascinated with the desert, in particular, the poster child of the desert, the saguaro cactus. The saguaro Carnegie gigantea can live It takes 75 years to develop an arm. It can live up to 150 years. It can grow to 40 to 60 feet tall. Carginia gigantea can develop fruit as well as have lovely flowers. Now, one of the areas that has been of great interest for my colleagues and I has been in the area of measuring disease-related symptoms. Here we have developed a series of questionnaires based on measuring fatigue, spleen-related symptoms, constitutional symptoms such as night sweats, and quality of life. We subsequently asked 9 additional questions regarding issues of mood, concentration, sexuality, and even blood flow, and have now developed the myeloproliferative neoplasm symptom assessment form that is offered in 12 different languages. Now, with efforts of this study, we performed an analysis, and many of you may have contributed, in over 1,400 patients. And with this, we saw in green that in myelofibrosis, issues of fatigue, night sweats are quite common. But what you see is that these issues are also very real in some patients with ET and PV. You'll see in the middle that itching is even most problematic in PV. Spleen-related symptoms, both in terms of their severity and prevalence, are most problematic in those with myelofibrosis. And finally, end organ-related symptoms are common across the board, but you see are not limited only in green to MF, but can be present in ET and PV. Now, one of the things that's evolving in MPNs is how we assess response. In other words, what do we expect of your therapy when you receive it? There has been a recent update, both from the European Leukemia Net for PV and ET, as well as for myelofibrosis from the International Working Group for Myelofibrosis Research and Treatment. And these thresholds are at complete, partial response, and no response. Now, with this, we see, 1, in ET, we expect these 4 different levels for a complete remission. Durable resolution, disease-related signs, including the big spleen and symptoms. Durable control of the blood counts. No evidence of progression, no blood clots or bleeding, and a bone marrow, which looks basically normal. And it's been A and D, the bone marrow and the resolution of symptoms and difficulties, that has been the most stubborn in the past. We measure these now using the MPNSAF and expect at least a 10-point improvement. In PVERA, similarly, very similar criteria, with the addition of having a controlled hematocrit not needing phlebotomies. And again, the difficult parts are not controlling the counts, but controlling signs, symptoms, and improving the marrow. Now, in myelofibrosis, the clinical picture is a little different. Again, we look at issues of marrow, counts, the blood, and clinical symptoms. And again, the holdouts can be symptoms and marrow. There are levels of partial response, and the most commonly utilized response, that of clinical improvement, whether it be in anemia, spleen, or in symptoms. So our revised MPN response criteria, they're clinically derived. What things matter to you? We recognize that they need to be durable, at least 12 weeks or more. We want to be able to measure them, but in the future we want to go back and say that by having achieved these levels of improvement, you were actually better off. You lived longer, you lived better, you lived happier. Now, saguaros can tell us a little bit about life. There's a lot of these guys out there in the desert that kind of stand by themselves and tell us that it's tough to walk the road alone. Indeed, the happier looking saguaro are those in clusters and tell us a journey needs friends. Now, what about phenotypic clusters? This is a medical term that means, what about different groups of patients within a specific MPN diagnosis? So let's take ET, for example. Here's 622 patients. There's symptoms along the left side of the slide you see, and each line along the bottom of the slide going up and down represents one individual patient with symptoms being absent in blue to being highly present in red. And we were able to find that statistically there were 5 different groups. And the 4 groups on the right were really quite symptomatic, and you saw fatigue all the way across the board. In PV, similarly, you see that there were 5 groups that were different, but overall there's more red on this slide with PV than there is the slide with ET, again a more symptomatic and difficult group. Now it can be dry in the desert. These guys, even though they don't need much water, they need some. So we all need water to grow and to thrive. Now what about risk? There's been many papers on risk in MPNs over the past few years. And risk is a measurement of saying how likely is something to happen. Is it risk of a blood clot? Is it risk of changing to acute leukemia? Is it risk of living with the disease? Across ET, PV, and MF, we have seen that age matters, a high white count matters, having a prior blood clotting event matters. We see that as we acquire features of advancing MF, low blood counts or anemia, constitutional symptoms or blasts that suggest movement toward acute leukemia, that the disease becomes higher risk. Now, how do these things compare to the symptom burden? Well, they're a little different. When we did our analysis comparing risk groups in PV according to how long they might, how life-threatening the disease is versus how difficult their symptom burden is, we saw that there was not a one-to-one relationship. Indeed, that symptoms could be bad across all of the symptom group or risk groups. Similarly in ET. Now in myelofibrosis, you see there were 4 groups. All 4 groups really have a lot more red than the ET and PV groups. But you see that there is a difference between that first group on the left and the brightest red group on the right. Again, is there a relationship with the risk scores? There is a trend. But there are patients who have high-risk disease who have less symptoms. There are people with low-risk disease with a lot of symptoms. So again, we must individualize it. Now finally, we looked at this data in a slightly different way, now with almost 1,900 patients. And we divided them into 4 equal groups and saw what total score of symptoms landed them in each group. So although the scores are potentially out of 100, the 4th group is for people with symptoms anywhere over 32. When comparing these, we saw that females, MF patients, and higher risk MF patients were the most symptomatic. However, when we line them up, we see that although the MF patients have the most significant symptoms, you'll see that there really are significant groups of patients in Q3 and Q4 with ET and PV who can be highly symptomatic. And looking at this graphically, yes, if you have ET, you're the most likely to have a low symptom burden, but it's no guarantee that you won't have symptoms. Likewise, MF is most likely to be problematic with symptoms, but there are exceptions. So what we're talking about is that you're not all the same. Indeed, like our friends in the desert, there can be tall, they can be short, they can have 20 arms, or they can have none. Now what about quality of life? When we analyze the Comfort 1 trial, in which we compared ruxolitinib to placebo, we saw that those in the placebo arm had a quality of life, fatigue, dyspnea, insomnia, and appetite loss that were worse than those individuals who have recurrent or metastatic cancers. Indeed, when we speak of quality of life, we must recognize that quality of life sometimes can be, as an overall concept, in the eye of the beholder. For some people, it's their car, having fun, eating good food, a good Wi-Fi signal for those in the back, or for many, when it truly comes down to it, family, friends, relationships define who we are. Now what about health-related quality of life? That's really what we're talking about today, is the aggregate of, do you have symptoms from your disease? And if you're on medicines, do side effects of the medicines make you feel worse? Have you had any prior complications from your MPN? What about the stress of having your disease? And meeting so many of you over the year, I've been inspired by your courage, but I also share your frustration, a disease that few people understand, and one that you sometimes feel that you have to explain to others and get frustrated doing so, in a disease that is not common. We also know that your health-related quality of life might be impacted by other illnesses you have, or indeed even by the hassle of medical care. So your health-related quality of life is really all of these things in aggregate. Now, finally, how do we try to incorporate all of these things in terms of coming up with a treatment plan for you as an individual? Well, as we look at patients with ET, PV, and MF lined up, let's say our goal is to prevent vascular events, blood clots or bleeding. We know a baby aspirin can be helpful. We know that phlebotomy or keeping the hematocrit under control is key for those with PV. We know that cytoreductive therapy is key. We know in those with cardiovascular risk factors, an area near and dear to my heart, controlling these is essential. We know that JAK2 inhibition has made a big impact on MF in terms of spleen size and symptoms, and even helping those with advanced disease live longer. We clearly are seeing that this can have similar benefits in PV. It might be helpful in patients with PV who have struggled or failed hydroxyurea or other therapies. We know that certain drugs like thalidomide or Revlimid can help improve low blood counts in patients with MF. And finally, we know that those with higher risk disease can benefit from an allotransplant. Now, what about interferon? Well, interferon has been shown by many, Dr. Silver foremost amongst them, as well as Dr. Kilajan from France, to help decrease the allele burden in PV, as well as help to control the counts, and in some perhaps decrease progression of the disease. Hydroxyurea has long-standing been an easy therapy. Many people do very well on it. Many people feel well on it. On that basis, there's a key trial I wish to highlight, the MPDRC 112 study. People within 3 years of diagnosis who've really not had prior therapy, randomized between pegylated interferon alpha 2A and hydroxyurea to see which of these two therapies is better. This is a crucial study that I highly encourage you to consider if you would be eligible, and that this will give us essential information in the future as to which therapy is best and help to move us forward as we try to look at new therapies alone or in combination. This clinical trial is open there in New York with Dr. Silver, Dr. Hoffman in Mascarenes, myself in Arizona, many sites in the Northeast and throughout the United States. Now finally, what about JAK2 inhibitors? You've heard these discussed today. You know there's quite a robust pipeline with ruxolitinib approved, fedratinib completing a phase 3 trial, pacritinib and momelotinib in phase 3 testing, the Lilly compound, NS Pharma all showing benefits. Now with ruxolitinib, in the area of symptomatic benefit, we demonstrated early on that proteins in the blood that were increased in red, or cytokines, could be turned to green or normalized with therapy with ruxolitinib, and this corresponded to people feeling better. We saw that people were able to walk further. They were stronger. They gained weight they had lost. In the randomized studies, we were able to show that people felt better whether we looked at it in aggregate or whether we looked at individual symptoms. We saw that compared to best alternative therapy, which was largely Hydrea, that patients felt much better on ruxolitinib. Indeed, when we compared ruxolitinib and placebo, between placebo and best alternative therapy between the two studies, we saw that neither one of these performed very well. We also saw that while patients were blinded, in green, that most patients with ruxolitinib felt quite a bit better, and those in gray who were on placebo did not. Now this is an example of some of the amazing things you can see in the desert. You see this almost dead-like stump on the left, but growing from that is a nice healthy green arm. So even from a tough foundation, new growth is possible. Now the good news is ruxolitinib is not alone in helping patients with MF. Fedratinib, or SAR 302503, has clearly shown benefits, and we look to see after ASH the quantity of those benefits. Pacritinib in phase 3 testing clearly can help people feel better, as can momelotinib potentially help people feel better, maybe even have an impact on anemia. Finally, those with PV can have improvement in how they feel, particularly those that have failed previous hydroxyurea, as have been reported earlier this year in long-term outcomes by our good friend Serge. So as we look at these drugs in comparison, you see that the issue of symptomatic improvement of JAK2 inhibitors has been present in MF, PV, and ET. So what do these benefits mean in aggregate? Well, the MPNs truly are diseases of plateau or decline. So what do I mean by this? If we think about a complete clinical status, let's say the asymptomatic patient, high platelet count, no prior vascular events with ET. That's one possible plateau. Now this individual, let's say they've had a blood clot or bleeding event. If they do, their plateau is at a lower level. Now what about PV? These patients in general have a lower plateau, even if they've not had a vascular event. If they've had a vascular event, the plateau is likely lower. Now let's say they have 6 months of worsening fatigue, weight loss, their spleen is big. They likely have post-PVMF. That is a decline. That is a worse state of being for them. Let's say they respond to ruxolitinib or a JAK2 inhibitor. Their weight's improved, their spleen is smaller, they're likely to live longer. In aggregate, this patient is not only at a better plateau, they're likely at a longer plateau. And this is a construct we could think about as we try to further and further improve the status, longevity, stability, and quality of life amongst those with MPNs. Now, we're interested in going well beyond just experimental therapies. We have, with the MPN Quality of Life International Study Group, 2 studies, the MEASURE study looking at impact of symptoms and quality of life of non-experimental therapies, and the symptom trial looking at it for those undergoing stem cell transplant. Now, indeed, as we look at our overall health, both all of you in the audience, as well as those of you who are caregivers who are in the audience, friends, loved ones, even us as speakers, we must recognize that our health is dependent on many things. There is the physical, but our mental, our spiritual, our emotional health are key, and they are key parts of the equation as we look at our overall quality of life, our overall health, and indeed setting our healthcare goals. So as we try to individualize the therapy for you, you must recognize that you must be front and center and party to making these decisions. Your symptom burden, how you are affected by the disease, is a key part of the equation. It's not, your symptoms are not everything by any means, but they need to be considered alongside all the other objective markers from the blood and the marrow. Clearly controlling the size of our spleen and keeping the blood counts not high and too low are important. Extending life is crucial, and clearly our goal is to cure the disease. I very much wish to thank my colleagues at Mayo Clinic in Arizona, 1 for putting up with me, and 2 for helping build a patient-centered program in the Southwest for patients who suffer from myeloproliferative neoplasms. I'd like to thank certainly many international colleagues, as well as most of the speakers on the panel who have participated in many of these efforts regarding quality of life for patients with MPNs. I'll leave you with these thoughts from my final Saguaro picture. It's tough being a Saguaro on a golf course in Arizona. Indeed, here's my golf ball sadly lodged into this poor fella. I truly wish each and every one of you the very best. I am most grateful and honored for the ability to be presenting to your group today, and look forward to joining you again in person in the very near future. My very dearest thanks.